Ok. Hoy vamos a hablar sobre neuritis óptica. Doctor John Chen nos va a acompañar hoy, aceptó esta invitación. Una breve reseña de su currículum. El doctor Chen estudió medicina e hizo su doctorado en la Universidad de Virginia. Estudió oftalmología y neurooftalmología en la Universidad de Iowa. Actualmente trabaja en los departamentos de oftalmología y neurología y es profesor asociado de la Facultad de Medicina de la Clínica Mayo. El doctor además es director asociado del programa de residencia en oftalmología y fellowship en neurooftalmología. El doctor Chen es copresidente y director del Upper Midwest Neuroophthalmology Group. También es miembro de la Academia Americana de Oftalmología y de la Academia Norteamericana de Neurooftalmología. Ha recibido diversos premios como la Academia Americana de Minesota, ha recibido premios en investigación y enseñanza y también fue elegido en el programa de desarrollo de liderazgo para la Academia Americana de Oftalmología 2020. Tiene más de 100 publicaciones y su principal área de investigación es imágenes oftalmológicas, hipertensión endocraniana idiopática y neuritis óptica. El doctor actualmente es el profesor del Departamento de Oftalmología y Neurología de la Clínica Mayo y le queremos dar las gracias por aceptar esta invitación. Thank you, doctor, for to accept this invitation. You are welcome.
Oh, thank you so much for the invitation to speak here. I'm very excited to speak with all of you, and thank you so much for that kind introduction. Let me go ahead and share my screen. Okay. Can you see my screen right now?
Okay, let me turn off my video and my microphone. Vamos a pedirle a todos que apaguen el micrófono y apaguen el video. Doctor, ready.
Great. Well, again, thank you so much. And it's really my honor to be chatting with you all over Zoom. I hope everyone is staying safe in this different times with the coronavirus pandemic. You know, the one small benefit or one of the small changes that we got from this is the fact that we're now more connected over Zoom than we've ever been before. You know, otherwise, you know, obviously there's been so many hardships with this. And again, I hope everyone is staying safe and healthy. So this afternoon, what I'd like to talk about is my favorite topic, which is optic neuritis. And it's my favorite topic, one of my passions, because of the incredible advances we've had over the past couple decades or so in terms of understanding atypical variants of optic neuritis. We now have biomarkers for antibodies against aquaporin 4 and for MOG that explain a disease called neuromyelitis optica and MOG-associated disorder. And these DMIND disorders are completely different from multiple sclerosis. Their prognosis is different, their treatments are different. And so now when we have a bout of optic neuritis, our dilemma is not just, does this patient have multiple sclerosis or not? We have to think about some of these other demyelinating conditions because it changes treatment, changes outcome. So hopefully at the end of this talk, you'll recognize the importance of thinking about Animo and anti-MOG. I have no financial relationships, but we are going to talk about some chronic immunotherapies for aquaporin 4 and MOG that are off-label. And we're going to start off with reviewing the differential diagnosis of optic neuritis. We're going to compare and contrast optic neuritis from multiple sclerosis, Animo, and MOG-associated disorder. And we're going to talk about treatments for these disorders as well. So I think most of this audience knows optic neuritis pretty well. It's essentially an inflammation of the optic nerve, typically retrobulbar, and it's the most common acute optic neuropathy in young patients. And so regardless of what kind of field of ophthalmology you practice in or neurology you practice in, you're probably going to come across patients with optic neuritis because, again, it's the most common acute optic neuropathy in young patients. Patients present with subacute monocular vision loss. Usually the vision progresses over a few days, gets nadir of vision loss at about 3 to 7 days. 90% of patients have pain, and oftentimes it's worse with eye movements. Patients report dyschromatopsia, where colors aren't quite as vibrant. And when we look at the disc in optic, the optic nerve typically looks normal. And if there is disc edema, it's typically mild, similar to this picture here, where you just get a little bit of disc edema, maybe a grade 1 disc edema. And that's because typically with optic neuritis, it's retrobulbar. The inflammation, the enhancement of the optic nerve is further back. And so the optic nerve head itself is actually spared. And that's for typical optic neuritis. And that's important to know because there's some atypical kinds of optic neuritis we'll talk about later, where you can have much more profound disc edema. And the good part is the majority of patients have recovery after optic neuritis. I tend to tell my patients that 90% of patients will get about 90% of their vision back. But there are patients that will end up with a poor outcome. In terms of typical optic neuritis, 3% will end up with a vision outcome of 2200 or worse. So not all patients recover, but the bulk do over a span of about 1 to 3 months after the bout of optic neuritis. A lot of what we know about typical optic neuritis came from the landmark study, the optic neuritis treatment trial, which recruited patients up until 1991. And this is the publication in New England Journal of Medicine in 1992. And essentially it found that high-dose IV methylprednisolone led to a faster recovery, but does not actually change the ultimate outcome. The outcomes were the same whether you're treating with high-dose IV steroids or placebo. They also found an odd result that a low dose of oral prednisone at 1 milligram per kilogram per day potentially increased the recurrence rate of optic neuritis. We don't quite understand if that's a true finding or a spurious result, but either way, after the time of the optic neuritis treatment trial, if you had a patient with optic neuritis, you really had two options. One is to treat them with IV steroids high dose to speed in the recovery, knowing that it doesn't actually change the ultimate outcome, or to observe. The only thing you don't want to do is give them a low dose of oral prednisone. And at the time of the optic neuritis treatment trial, really the main dichotomy when we have a patient with optic neuritis is whether this patient has multiple sclerosis or not. And so the other big thing that the optic neuritis treatment trial did is it actually stratified that risk of developing MS after optic neuritis. And so again, the big question, what is that risk? And the good part is it's actually a pretty easy number to remember. It's 50% at 15 years. And again, it's a very important number to remember because, again, you're going to see patients with optic neuritis, or you might have a friend or relative with optic neuritis. And the first thing going through their mind is, well, what is my chance of developing MS? And overall, it's 50% at 15 years. And then the risk is further stratified depending on the presence or absence of white matter lesions. And so if you get an MRI at the time of the optic neuritis and it's completely clean, there's only a 25% chance of developing MS. But if you have white matter lesions, especially if they're periventricular, there's a higher risk, 72% if there's white matter lesions. And then if you get these classic periventricular white matter lesions shown here, these are called Dawson's fingers. You can see why they're called fingers as they come across the ventricles there. And there's a higher risk. And so you can further stratify that risk depending on the MRI at the time of the optic neuritis. Optic neuritis with multiple sclerosis, that's your typical optic neuritis that you see. It makes up about at least 50% of optic neuritis, at least in Caucasians. And we all have a gestalt idea of what we think about a typical patient with optic neuritis. And classically, it's going to be a young adult female. Caucasians are affected more than Blacks and Asians, at least for multiple sclerosis. The vision loss is classically mild or moderate, but sometimes it can be as severe as no light perception. Typically, patients have good recovery. The disc edema, if it's there, it's only there in a third of patients. It's going to be mild. And of course, with multiple sclerosis, you get these periventricular white matter lesions. And so this is your classic patient with MS with classic optic neuritis. So I want you to just keep this kind of patient in mind as we talk about other different forms of optic neuritis that are more atypical. So if we can compare and contrast them. So again, at the time of the optic neuritis treatment trial, the main dichotomy is MS, not MS. And within the non-MS group, we've got idiopathic, we've got infectious and inflammatory conditions, which only make up a 2%, 3% of optic neuritis. But you want to think about them if you've got something atypical. And so you have to think about all those inflammatory autoimmune conditions that can affect any part of the eye, like sarcoidosis, lupus, granulomatosis with polyangiitis, and then some of the infections that can affect any part of the eye, Lyme, syphilis, TB, and zoster. And depending on your area, you've got a higher suspicion of one than the other. And so again, the main dichotomy at the time of the optic neuritis treatment trial was this MS, not MS. But we've also known about Animo for over a century, neuromyelitis optica, and there was a lot of debate in terms of trying to figure out where this disease falls within the MS or not MS spectrum. So again, we've known about it since 1894 when Devik and Galt first described their series, and that's why another common name for this is Devik syndrome. And we know that it causes severe relapsing optic neuritis and severe longitudinally extensive transverse myelitis. And here's just an example of a patient who had Animo, where they had a prior optic neuritis in the right eye that left them count fingers. So very atypical. They didn't have that recovery that we typically get with multiple sclerosis. And then unfortunately had a recurrent bout of optic neuritis in the left eye, leaving them 2400. And then they also had a prior transverse myelitis. And the time of the scan, you can see here that there's this T2 signal that extends 5 vertebral segments. And, and that's classic for Animo. And that's why these patients have such severe weakness and motor impairment and from these transverse myelitis attacks because of how much extensive inflammation you have. Whereas multiple sclerosis can obviously cause transverse myelitis, but this is a more typical lesion we get where it's much shorter, less severe. And so the name of the game for Animo for over a century is severe relapsing optic neuritis, severe transverse myelitis. And those were really the two phenotypes we knew. And for the longest time, that you can see this is in 2007. So, 15 years after the optic neuritis treatment trial, we're still debating, is Animo a distinct entity or is it a part of MS? And there are arguments on both sides. Some saying it's a variant of multiple sclerosis, some experts saying it's a separate entity. But ultimately, the answer came from the laboratory. In 2004, Dr. Lennon and colleagues at the Mayo Clinic actually discovered an Animo antibody against aquaportin 4 that was both a marker and a pathogenic cause of Animo. And that firmly cemented Animo as a distinct entity for multiple sclerosis. So aquaportin 4 in our bodies is a water channel protein that's expressed on the astroglial foot product and is expressed primarily in the brain, the spinal cord, and the optic nerves, which is why Animo has such predilection to brain lesions, transverse myelitis, and optic neuritis. When aquaportin 4 antibodies binds to aquaportin 4, it activates complement, and that causes astrocytic injury. And this antibody is very specific, especially if you have a cell-based assay. The specificity is 99.8%, and then it picks up 76% of Animo, because you can have Animo without the antibody, which we'll talk about shortly. So this is 2 years after the discovery of the antibody. Wingerchuk came out with these diagnostic criteria, where essentially you needed to have optic neuritis and transverse myelitis and at least 2 of the following, either a long transverse myelitis, an MRI non-diagnostic for MS, or positive aquaportin 4 antibody. So at this point, it was pretty easy to remember. But now that we've got a specific marker for disease, the spectrum of what Animo can cause has greatly expanded. And so this is the most current international diagnostic criteria published in 2015. And obviously it's too complicated to read here, but I did want to highlight the core clinical characteristics. So the two most common characteristics are still...
Chen. Yes,
Yes, are there any questions? I'd be happy to answer any questions anywhere along the way as well.
no, it's okay. Sorry.
Okay,
No.
great. So the core clinical characteristics remain optic neuritis and transverse myelitis. But the third most core clinical characteristic actually was found to be areopostrema syndrome, where patients can get refractory hiccups and vomiting from a lesion within the brain. This was actually published in the New York Times Magazine just this past fall, where a 40-year-old female had these terrible heartburn, vomiting, retching for 3 months at a time. Had a $1 million GI workup, went to the ER multiple times, endoscopy, colonoscopy, no one could figure out what it was. And then it just vanished. 3 months of horrible symptoms and it vanished. And then a year later, she developed it again and she's like, oh, not again. But this time she had double vision, which led to an MRI and it showed a lesion in the areopostrema. And this was Animo all along. And areopostrema syndrome occurs in about 10 to 20% of patients with Animo. It can be the presenting symptom in up to 10%. So it just means we have to think about these other ways the Animo can present, because it's not just optic neuritis and transverse myelitis. And that means doctors outside of ophthalmology and neurology actually have to think about Animo, because this could be a patient in ED, this could be a patient in a GI clinic. The other core clinical characteristics that patients with Animo can have is acute brainstem syndrome, symptomatic narcolepsy, and symptomatic cerebral syndrome. And to make the diagnosis, you need one core clinical characteristic and the antibody with the cell-based assay, which is again very specific. Or you can actually make a diagnosis of seronegative Animo if you have two core clinical characteristics, as long as one of the two has to be one of these three main ones. And so Animo has a very large variance in terms of prevalence, and that's because it has a very large difference in ethnic predilection. In Caucasians, it only explains about 1 to 3% of demyelin disease, whereas in Asians, it explains 20 to 48%. And actually, before the recognition of Animo, there was this Asian variant of MS that they called optospinal MS. And, in retrospect, that was Animo all along. We, at the Mayo Clinic, we did a comparative study looking at the incidence of Animo in Rochester compared to Martinique. Rochester, which is 82% Caucasian, only had an incidence of 0.7 per million, whereas Martinique, which is 90% Black, had a 10-fold higher incidence. And so again, it just shows that large difference in terms of the ethnic background, in terms of when to suspect Animo. It's 3 to 7 times more common in women, and the median age is 39, so a full decade older than your classic patient with MS. And so going back to our classic patient with MS compared to Animo, with Animo, it's going to be a little bit of an older patient, even more female predominant than MS. Black and Asians are more affected than Caucasians. These patients have severe vision loss at onset with poor recovery. This is why we see them and why in ophthalmology clinic, because of the fact that the vision can be very poor. Up to 50% can end up with a vision of 2200 or worse. Much different from your typical case of multiple sclerosis. Oftentimes the enhancement is retrobulbar, and so they have typically less disc edema. It can actually cause isolated optic chiasm involvement, which is very rare in MS. So if you see chiasm involvement, you want to think about Animo. And of course, the classic long transverse myelitis. And you want to think about areopostrema syndrome with these intractable hiccups and vomiting, where it hits that area in the medulla. What's pretty scary about this disease is that mortality rates for NMO range from 6 to 32%. Fortunately, now with better treatments, I'm sure we're much closer to 6%. We're probably better than 6% now that we've got better recognition, better treatments. But left untreated, this can be a fatal disease. We need to recognize these patients early because the attacks are so severe, we treat them very aggressively. We treat them with immediate IV corticosteroids. We don't give them the option of observation versus treatment. It's not like multiple sclerosis optic neuritis that's going to recover on its own. We treat them aggressively. And we end on plasma exchange pretty much as soon as they finish the IV steroids and aren't starting to recover, we add on plasma exchange. In Europe, they often do plasma exchange even faster than we do in the US, but we add on plasma exchange usually within the first week for these acute attacks. The other main difference is the treatment. Any patient with NMO that's aquaporin-4 positive requires long-term immunotherapy. That's because they tend to relapse, and with each attack, the recovery is often poor. So we need to try and prevent these attacks from happening. Rituximab is the classic first line. Some other medications that are used in the past are azathioprine and mycophenolate. They all probably cause a reduction in relapses, especially rituximab. But one thing, if you're going to take away one thing from this talk, is that MS medications are not effective for NMO, or at least the classic ones. Not only are they ineffective, they may actually even increase the relapse rate. And so that's why it's so important when you have a patient with optic neuritis to think, could this be NMO? Because if you misdiagnose them with multiple sclerosis, they end up getting put on interferon. They could potentially worsen the disease. So have to think about NMO. And that's in a disease that untreated has a mortality rate as high as 32%. We've got to diagnose them. We've got to treat them appropriately. It's been an exciting time to be a neuro-ophthalmologist. The AAN actually called 2019 the year of NMO. And that's because there were 3 separate clinical trials, randomized clinical trials that actually showed 3 separate medications were very effective for preventing relapse in NMO. The first one that was published was the PREVENT study, and this looked at eculizumab, which is a complement inhibitor. And this was an amazing study because it showed a 94% reduction in relapses compared to placebo. It was also really nice because it knew that aquaporin-4 antibodies binds to aquaporin-4 and activates complement, and therefore it actually used the pathophysiology of the disease to think that this could be a good medication, and it was. It became the first FDA-approved medication for NMO spectrum disorder, and so we've got that in our back pocket in case a patient relapses through rituximab. The next study was NMO Momentum study, and here the study looked at enobolizumab, a CD19 inhibitor, and it also showed a very significant drop in relapses compared to placebo. And most recently, the Secure Star study looked at satralizumab, which is an IL-6 inhibitor, which showed a significant decrease in relapses in patients with aquaporin-4 NMO. But interestingly, there is some patients that were seronegative NMO, weren't positive for aquaporin-4, and satralizumab did not appear to be effective for those. So again, we've got our NMO spectrum disorder that are aquaporin-4 positive, and then we've got our seronegative NMO, which may be a slightly different entity. But again, these 3 trials, all successful, published this past year, and it's just really nice to have these other options in case these patients break through some of the traditional medications like rituximab. And so going back to our diagram in terms of where we are, we've known about NMO for over a century, but now we know that it is not a subset of multiple sclerosis, that it's its own entity, and we've got a wonderful marker for it, aquaporin-4 antibodies, 99.8% specificity. But as you can see here, it's only positive in 75% of patients, which means a quarter of patients don't have this aquaporin-4 antibody, which means there has to be at least one or two or three other antibodies that can explain some of these. And most recently, over the past several years, it's been recognized that antibodies against MOG can explain a third of these cases that were seronegative NMO. It also explains some very atypical variants of multiple sclerosis, and many cases of idiopathic recurrent optic neuritis are explained by antibodies against MOG. So because MOG-associated disorder is a little bit more newer, I thought I'd just start off with a classic case of a patient with MOG. This is a 48-year-old male who presented with blurred vision and pain in both eyes. And you can see here prominent bilateral disc edema, either even some peripapillary hemorrhages in that left eye. This patient was count fingers in both eyes. I actually remember one of my ophthalmology residents saw this patient in the ER, and they saw this bilateral disc edema, and they said, Dr. Chen, I've got a patient with bilateral papilledema. I think this patient needs an MRI, an MRV, and a spinal tap. But in reality, this patient, as you can see, is count fingers. And yes, there's a lot of disc edema, but this is kind of a grade 3 disc edema. It's not your fulminant IIH or fulminant tumor kind of patient that would be count fingers in a span of a day. And so this patient didn't need the MRI, MRV. This patient needed a directed MRI of the orbits. You've got to look for that optic neuritis. And what you can see here in this patient is that there was bilateral prominent enhancement of the optic nerves. And what's interesting about this patient MRI compared to, let's say, an MS patient is that there's a lot of enhancement. It extends down the entire orbit. And the enhancement is so severe that it involves the sheath, and it spills into the peribulbar fat, which we call perineural enhancement. And this is actually a very classic sign for MOG optic neuritis. But looking back at our differential diagnosis of optic neuritis, looking at that disc appearance, that MRI, I would actually argue that you could probably rule out MS and aquaporin 4 NMO because they're not going to have that much disc edema. They're not going to have peripapillary hemorrhages. They're not going to have that much enhancement on the scan. And so all these others are fair game for this kind of appearance. But again, this is classic for MOG optic neuritis. So at the time, the patient was diagnosed with atypical optic neuritis. It's atypical because it's bilateral. There's a lot of disc edema. And the initial workup was negative. There were no oligoclonal bands. The aquaporin 4 antibody was negative. The infectious inflammatory workup was negative. And again, this was several years ago before we even had the MOG assay up and running commercially. At the time, the patient was treated with IV methylprednisolone for 5 days, and the patient had amazing recovery of vision back to 2020. But it was essentially immediate. On day 2, he was back to 20/40. By day 3, he was 20/20 of the IV steroids. And anyone who deals with typical optic neuritis knows that's actually faster than we would expect for typical optic neuritis, which we do often do IV steroids, but it makes the recovery happen at 2 to 3 weeks instead of 6 weeks. Here, it was within 2 days of IV steroids, they're back to 20/20. So it's almost too fast. Unfortunately, with this patient, when we tapered off the steroids, they had relapses. And so they had so they were very steroid responsive. Every time we treated them with steroids, they did great, but they were steroid dependent. Every time we came off the steroids, they had relapses. And so clinically, this is chronic relapsing inflammatory optic neuropathy because it's steroid responsive, but steroid dependent. And this patient was stabilized on azathioprine 100 milligrams twice a day. And, unsurprisingly, this patient's antibody against MOG was positive at 1 to 100, which is a pretty high titer. And again, so this is just kind of your classic case of MOG optic neuritis. Not all of them are going to look like this, but if you have a patient that looks like this, you want to think about MOG antibodies. So MOG stands for myelin oligodendrocyte glycoprotein, and it's a transmembrane protein found on the surface of oligodendrocytes and myelin. And MOG antibodies have been speculated to be involved in demyelination for many, many years because it's one of the most commonly used animal models of demyelination. in the experimental autoimmune encephalomyelitis. And so for decades, this is thought to be involved, or at least a marker of demyelination, but we didn't know how it fit in. And it's interesting, in the early 2000s, it was actually thought to be a marker of multiple sclerosis. This was a paper published in the New England Journal of Medicine where it seemed like these antibodies against MOG were a marker of multiple sclerosis, but these weren't able to be replicated because these assays back then use Western blots and other assays that are not as specific. We now, because with these Western blots, you're not expressing MOG in its conformational form. With these, you've got denatured MOG protein, and it just doesn't work. To be able to detect MOG reliably, we actually need to use a cell-based assay. And how that works is we take HEC293 cells, and we actually express MOG in the cells, and therefore it's expressed MOG on its surface, and it expresses it on its conformational form, exactly how it would be expressed on a cell on its surface membrane. So not denatured, but its conformational form. And that's what allows for the increased specificity. So then we didn't take human serum that may have the antibodies. We then put them on the cells that are expressing the MOG, and then we detect the binding with IgG1 specific secondaries. But it's really this cell-based assay of expressing MOG in its conformational form that allows for the increased specificity of the MOG assays that we have now. And the MOG cell-based assay has been commercially available at the Mayo Clinic since October 2017. And that was actually the first MOG assay that was commercially available in the US. Fortunately, now in 2019, we've got a couple other labs that are offering MOG, so it's easier to get. But it just shows that it really has not been around that long. 2.5 years of having a commercial antibody is not that long for a disease that actually is probably 2 times as common as NMO. So the spectrum of MOG-associated disorder is expanding now that we've got a pretty specific marker. It is distinct from MS. It seems like it can affect any age range between 1 and 82. The median age is 33, but it really affects children quite a lot. It actually makes up to 20% of demyelinating attacks in children. Up to 50% of attacks of ADEM are actually MOG positive. And it still makes up about 5% of demyelinating attacks in adults. Unlike MS and NMO, the male to female ratio is much closer to 1:1. It might be slightly more female predominant, but it's much closer to 1:1. And as far as aquaporin 4, it's 2 times as common. So it's something you're going to probably see in your ophthalmology clinic. The most common way it presents in adults is optic neuritis, especially recurrent optic neuritis. It's isolated in 50% of the time, and in 50% of the time, it can have other neurologic manifestations, which we'll talk about. It explains about 25% of chronic relapsing inflammatory optic neuropathy. Features that, if you see a patient with optic neuritis, that would make you want to think about MOG is that if they've got bilateral optic neuritis, which is about 50%, if it recurs, which also occurs in about 50%, especially if there's that steroid dependency, like in our Dick's case that we talked about. If you see disc edema, especially severe disc edema, you want to think about MOG. Up to 86% of disc edema, about half have moderate to severe disc edema. And again, rarely you can even have disc edema that's so severe that you have peripapillary hemorrhages. The MRI, which we talked about, is a large clue. If you see that optic nerve sheath enhancement, especially if it spills into the peribulbar fat, that's very suggestive of MOG optic neuritis. That happens in about 50% of patients. So if you don't have it, it still could be MOG. But if this sign is there, it's very specific. We don't expect to see this with NMO or MS. And similar to NMO, it can be bilateral, and it can be very long lesions. That's very, very long lesions. We see this in about 80% of patients with MOG optic neuritis. The extensive inflammation is probably why when they present, they actually present with severe vision loss, average of 2,200 to as bad as count fingers, sometimes NLP. They present very severely. But the good part is patients with MOG optic neuritis tend to recover much better than aquaporin 4 Animo. This was a study where we looked at patients with recurrent optic neuritis, and this is the chance of retaining good vision. And what you can see here in blue is this is our patients with aquaporin 4 NMO who are getting recurrent bouts of optic neuritis. And as you get recurrent bouts of optic neuritis, the chance of maintaining good vision is very low. But here in pink is our patients with MOG optic neuritis. And despite multiple recurrent optic neuritis attacks from MOG, patients tend to retain good vision. And you can see here that the outcomes are actually similar to our MS group that had a recurrent bouts of optic neuritis. And overall, about 6 to 10% end up 2,200 worse for MOG, and compared to that 50% mark that you can get with aquaporin 4. So again, patients present with severe vision loss, but outcomes are much better because they recover so much better than aquaporin 4. So again, the most common way that presents in adults is optic neuritis. It can also cause transverse myelitis, typically not recurrent, but it can happen. And oftentimes there can be long lesions. As you can see here, this extends pretty far down, about 5 segments, very similar than what you see with NMO. In some patients, you can see this interesting sign where it just affects the central gray. And in this paper by Dubé, one of our colleagues at the Mayo Clinic, you can see he called this the H sign because, again, it looks like an H. But if you're a sports fan, you can maybe call it the Under Armour sign. And if you're a science fiction fan, you can call it the TIE Fighter sign. But regardless of what you call it, if you see that central gray being affected that looks like an H or a TIE Fighter, that's how you're going to say, well, maybe this is MOG optic neuritis and it's not going to be NMO, despite having such a long segment of enhancement there. And of course, if you've got optic neuritis and a longitudinally extensive transient myelitis, that actually meets the current 2015 diagnostic criteria for NMO. And as we talked about, it actually explains a third of seronegative NMO. And the future diagnostic criteria will clearly put MOG as a separate entity, but currently it does meet the criteria for NMO spectrum disorder if you can have that optic neuritis in that long transverse myelitis. The other way that it commonly presents is acute disseminating encephalomyelitis, or ADEM. And here patients present with this multifocal CNS inflammation. You can see this patient here has multiple lobes being infected. This predominantly affects children, but it can affect adults as well. And these patients were, in the past, kept me up at night when we didn't have this biomarker for MOG, because again, these were often children, an 8-year-old children coming in bilaterally blind, encephalopathic with these horrible headaches. We get these scans and we've got this inflammation throughout the brain. And, at the time we were trying to decide, is this inflammation? Is this infection? What is this process? And a lot of these patients, we ultimately bit the bullet, treat them with steroids, and they got so much better. And in retrospect, all those patients that kept me up at night, those were MOG. Those were patients that had MOG-associated disorder. Some of them actually even ended up with brain biopsies because we didn't have a marker, and some of them were doing poorly. So it's great to have now a nice biomarker to explain a lot of these atypical cases in the past. Another thing to note is it's not multiple sclerosis. It's a separate entity. So they have a classic phenotype for MOG-associated disorder. You can tell them that you're not going to get multiple sclerosis. It's a separate entity. And so here's some diagnostic criteria that our group published. And essentially, it all stems on having a reliable cell-based assay. And that's obviously what needs to be part of this spectrum that's still growing. And then you'd have to have one of these clinical findings that we just talked about. And it really is a distinct entity. It's very rare for classic MS to be positive for MOG. The specificity for the MOG assay is probably around 99%. And so if you test enough patients with classic MS, you're going to get a false positive, 1 out of 100. But it's rare for classic MS to have certainly a high titer. But you might get some low titers, that 1% kind of range. We know it's distinct from MS because if we do have a patient with MOG-associated disorder, the MS medications are ineffective. It's also clearly distinct from aquaporin 4 Animo. There's, again, almost no patients that are positive for both MOG and aquaporin 4. And then on pathology, for patients that actually ended up getting a brain biopsy, it's entirely different, where aquaporin 4 has astrocytic destruction and secondary demyelination, and MOG has more of a pattern 2 demyelination. And again, we talked about the outcomes. They're much better. And treatments probably are probably different as well. So let's talk about treatment. So with acute attacks of MOG optic neuritis, we tend to treat them with IV methylprednisolone for 3 to 5 days, followed by an oral prednisolone taper over 1 to 2 months. So a little bit different than both MS and aquaporin 4 Animo. With MS, you can treat or not treat, outcomes are going to be the same. With MOG, we think that treatment probably does improve outcomes. And we tend to do, and then it's different from aquaporin 4 in that some of these cases are steroid dependent. So we often do this longer prednisone taper, whereas with aquaporin 4, it's IV steroids and Plex. For MOG, because most patients tend to recover, we typically reserve plasma exchange or IVIG if the vision loss is severe and there's no recovery after 1 to 2 weeks. Then we add those on. Again, different from aquaporin 4 Animo, where we're adding these plasma exchange almost as soon as we can. Another divergence is the chronic treatment. For MOG-associated disorder, only 50% are going to relapse. And each attack is so much better than NMO. And so if a patient has a single attack, we typically do not treat them with chronic immunotherapy. And we reserve long-term immunotherapy only for patients that have relapsing disease when they start accumulating neurologic deficits. And then in terms of the treatment, if you are going to treat them, what is the best medication? We recently completed a multi-center retrospective review of 69 patients treated with chronic immunotherapy. And a couple of things that I just wanted to show here is this, in this column is the pre-treatment annualized relapse rate. So that's how often do they relapse per year. And in this column, this is the post-treatment annualized relapse rate on the medications. And the first medication I want to show you here is the MS disease modifying agents. And you can see here that they're not effective for MOG. Prior to treatment, it was 1.8 relapses per year. Afterwards, it was 1.5. And so really, these MS disease medications don't work. But fortunately, it didn't appear to worsen the disease, unlike NMO where it can. For the standard medications, the classic ones that we use for NMO, you can see a reduction in all the attacks for mycophenolate, azathioprine, and rituximab. But you can see that the annualized relapse rate does not drop to 0. There are breakthrough attacks through some of these. And again, this is a predisposed group of patients that have relapsing disease already. But certainly these medications appear to cause a reduction in attacks, but they're not perfect. What was interesting is that monthly IVIG tended to cause the largest reduction in attacks. You can see here the pre-treatment annualized relapse rate was 2.8, and afterwards, only 10% of the patients relapsed. The drawback here is that our number of patients here is only 10. And so, clearly we need larger studies, randomized prospective studies to prove that IVIG is effective for MOG-associated disorder. But it's something that we definitely keep in mind. And so when we see a patient with MOG-associated disorder, we still typically start with either rituximab or azathioprine, sometimes with a low dose oral prednisone, about 10 milligrams. But if they relapse through these treatments, then we will go to monthly IVIG based on that multi-center retrospective review. Back right before this COVID pandemic, I was actually just in Germany with a bunch of MOG experts around the world, and many others are actually finding that IVIG is also very effective for MOG. So it's not just here in the US, but really around the world that people are finding that these medications are helpful. But because of the cost and the monthly infusions, we still typically start with some of the more classic medications like rituximab or azathioprine. But it's good to know that we have IVIG in our back pocket if we need it. So I think, one thing maybe some of you may be wondering, well, will I ever see aquaportin 4 or MOG in my clinic? Or is it just this rare zebra I don't have to think about? Obviously at the Mayo Clinic, I see it a lot, but we've got this huge referral bias toward MOG disease, toward Enimo. But also what's nice is we've got a study, a unique system here called the Rochester Epidemiology Project, where we can actually look and see what the population-based incidence of various diseases are. And in 1985, one of the most commonly quoted studies was this one here, where it showed that 52% of garden variety optic neuritis was MS, 48% were idiopathic. And this is a population-based study, so just patients within Olmsted County, not ones getting referred from California for an atypical optic neuritis. These are just patients in our backyard who get all their care at the Mayo Clinic. They found that the vast majority were MS, but this study was done before the knowledge of aquaportin 4 and MOG, and so given these new biomarkers, we actually did an updated incidence study trying to see how common these are. And we found is 57 were MS, 31% were idiopathic. So you can see that idiopathic level definitely dropped. And we found that 3% were aquaportin 4, 6% were MOG. And therefore, 9% of the optic neuritis is going to be Animo or MOG. And so if you see enough optic neuritis, you're going to see one of these conditions. So you want to think about these. You want to keep these on your differential diagnosis. We recently published a review article on optic neuritis in terms of how we approach optic neuritis now that we have these biomarkers. And I just wanted to step through the way we've kind of changed our thought process, starting with the workup. First is, the classic teaching is that optic neuritis is a clinical diagnosis. And we get the MRI brain to stratify the risk of multiple sclerosis or not. But now that we actually have these interesting enhancing patterns that may suggest one or the other, we actually recommend an MRI brain and orbits to see if there's these atypical features. Because if you see a lesion with this classic perineural enhancement, you're going to think MOG optic neuritis. If you get isolated chiasmal involvement, you want to think about aquaportin 4. And so now when we have a patient with optic neuritis, it's MRI brain and orbits. Another big question is, well, when do I test for aquaportin 4 and MOG? Do I do it on every patient? Do I not? I think you can consider it testing for these in any optic neuritis, unless it's classic MS. If they've got periventricular white matter lesions, they're in the correct demographic, they've got oligoclonal bands, mild optic neuritis, complete recovery, that's going to be MS. These tests are good, but they're not 100% specific. So if you test enough MS patients, you're going to get a false positive here and there. So if they're classic MS, I wouldn't test them. But if they're not classic MS, I would certainly test for aquaportin 4, because that's even more specific than MOG, and it completely changes management. It changes the diagnostic paradigm. I think you should test both aquaportin 4 and MOG for any atypical optic neuritis. And so that'd be any patient with severe vision loss, if they've got bilateral optic neuritis, that long segment enhancement, perineural enhancement, all those kinds of things will make you want to think about testing for that. And then if you have any other neurologic attacks that aren't classic for MS, you'd want to think about testing for it as well. Edema, long transverse myelitis, area postrema, and of course, anything atypical for MS. So if you do want to test, you want to test the serum. It actually has higher sensitivity than the CSF. And you want to make sure it's a cell-based assay, because it's going to have higher sensitivity and specificity than ELISA or any of the other assays that are out there. And the specificity is excellent, 99.8% for aquaporin 4, MOG between 98 to 99%. And because MOG assays, again, have you're going to get a couple false positives here and there, you want to pay attention to the titer. If it's 1 to 100, 1 to 1,000, those are high titers. Those are much more likely not to be a false positive. But if you get a 1 to 20, a 1 to 40, have to think, maybe this could be a false positive despite this excellent specificity. Just have to keep that in mind. So very briefly about treatment. We've actually talked about this already but the one thing that I want to mention is that we tend to treat almost all optic neuritis that has severe vision loss with IV steroids. And the reason why is that these antibodies for aquaporin 4 and MOG take usually 1 to 2 weeks to come back. And we think that early treatment may lead to better outcomes. And so we're not going to have the antibodies right away. So if it's bad vision, 2200, I don't really give them the option. I just say we've got to treat with IV steroids. And there was actually a recent study by Dr. Kalish and colleagues where they actually looked at patients with aquaporin 4 and MOG, and they actually found that patients treated within 7 days had a better treatment than patients treated outside 7 days. So again, if they've got severe vision loss, I don't tend to give them the option. I really try to push IV steroids as soon as possible. And then if they're aquaporin 4 positive, they're aquaporin 4, that's when you're going to do your plasma exchange. For MOG, optic neuritis, you're going to do your IV steroids with that longer oral prednisone taper, and then consider plasma exchange or IVIG if they're not recovering. And then the chronic immunotherapy we talked about already. For MS, obviously an MS disease-modifying agent, aquaporin 4 Animo, they need the immunotherapy for any patient that has aquaporin 4 antibodies. And if they're MOG antibodies, they only need treatment if they're relapsing. So I just thought I would summarize kind of these differences between these various demyelinating syndromes. So for MOG, it can be any age, any sex. Remember, that was the one where the male and females were pretty similar. And of course, any pediatric demyelinating event you want to think about MOG. So far, we don't think we have a racial predilection for MOG yet, but more studies are required for that. MOG, like Edema, has severe vision loss at onset, but the good part is the recovery is much better. The disc appearance is going to make you lean one way or the other. If you see a lot of disc edema, you want to think about MOG. If it's bilateral, it could be MOG or aquaporin 4, much less likely to be MS. And then the appearance of the MRI enhancement pattern is going to help you. Here's that classic perineural enhancement that you get for MOG. Present in only 50%, but if you have it, it's pretty specific. Isolated Kai's involvement, you kind of want to think about aquaporin 4. With MS, it tends to be these shorter segments of enhancement. The transverse myelitis can help you, short for MS, long for NMO and MOG. Of course, that MOG had that H sign where the central gray is affected. And then lesions outside the spinal cord in the brain can lean you one way or the other. If you see area postrema syndrome, that's much more common aquaporin 4 NMO. If you see ADEM, you're going to be thinking MOG. Periventricular white matter lesions, that's your MS. And so this is kind of the twisting way we kind of got to NMO, how we got to MOG. But in reality, these are all separate entities. You have a patient with optic neuritis, and you have to think about each of these. Is this MS? Is this MOG? Is this aquaporin 4 NMO? And what's interesting is, as we showed with the recent study where we looked at all these patients with optic neuritis, over 30% are still idiopathic. And so there's still unknown antibodies out there. And there's probably some odd multiple sclerosis cases that we can kind of pull out of multiple sclerosis as well. So there's more work to be done. It's pretty exciting to see our understanding of MOG-associated optic neuritis expand. But again, there are other markers to be found. So in summary, I hope you could take away from this talk is that optic neuritis has multiple causes. We have to think about multiple sclerosis, aquaporin 4, NMO, and MOG. These antibodies against aquaporin-4 and MOG have to be tested for any atypical optic neuritis because the treatments are different from these entities. It changes prognosis, changes treatment. We just have to think about them for any atypical optic neuritis. So I just wanted to thank a lot of my collaborators, and there's even more collaborators beyond this list, but especially at the Mayo Clinic, Owen Flanagan, Tarek Bhatti, Sean Priddock, we're constantly talking about ideas and better ways to understand these diseases. And then the neuro-ophthalmologists in the US are phenomenal, and we've had great collaborations from all of them. And so I just want to thank all of you for your attention, and I've had a great time chatting with you. I'd love to answer any questions, and I know I was only slotted an hour, but I'd be happy to stay on and answer any questions, go over anything that might come up, especially with Zoom. If you have to go, you can leave at any point. So I'll stick around as long as anyone wants to chat.
Thank you, doctor. Excellent talk. Wonderful. Let me see. We had some questions. Let me see. Great talk, always brilliant. I have a question they sent me from my private chat. They say, the differential diagnosis between retrobulbar optic neuritis and malingery, do you think that VPs can be useful?
Could you say the differential diagnosis of
retrobulbar optic neuritis and malingery?
And what was the second one?
Malingery.
Oh, malingering.
Yes.
Is that right? Okay. Yes, malingering. So yeah, the good part is essentially functional vision loss or non-organic vision loss. That's something we see a lot.
Mm-hmm.
We've got lots of different ways of determining non-functional vision loss. It's interesting because most of these patients aren't malingering. They're not trying to get gain. Most of them are a somatoform disorder where, they truly think they can't see. And, it might be some kind of traumatic event that caused this. But we've got a lot of great tests. I would start off clinically, and if it's one eye, you can look for the relative afferent pupillary defect, because if it's real, you're going to have that. You can do, if it happened 3 months ago, OCT is incredibly sensitive in picking up prior optic neuritis. So if they've got a normal OCT that's symmetric, that would be a large argument against. If they've got MRI enhancement, if there's enhancement, obviously that's real optic neuritis. And then there's visual evoked potential. And it's something that occasionally we'll do. I don't typically do it for unilateral optic neuritis because that you can tell we've got so many tests to prove unilateral functional vision loss or non-organic vision loss. But if it's bilateral, sometimes we'll use it to prove that the visual function is normal. But for the most part, my patients, I get a visual field, OCT, MRI, clinical exam. I rarely do visual evoked potentials.
Okay, let me check if we have another question here. Okay, let me see here. They say, great presentation, thank you. Yes, please.
That was great as always, John. One question.
Sorry.
In the Olmsted County 30% idiopathic, what's the natural history of those patients and how do you treat them?
Yeah, so essentially you get this idiopathic optic neuritis. We tend to put those into the clinically isolated syndrome. Single attack, we just let them be. And then, some of those patients over time, they may develop MS, they may develop something else. But yeah, single optic neuritis, I usually check them for MOG, check them for aquaporin-4, and then just observe. If they relapse and they still don't have any biomarkers and they're starting to lose a lot of vision, then we treat them just like we used to treat all these patients with MOG, and we didn't know what the entity was. We'd put them on azathioprine, rituximab, something to try and prevent those relapses. But single attack, we just kind of leave them be and hope they never have another attack again. So in this Olmsted cohort, these were obviously not referred patients. Majority of those idiopathic ones were single attacks and did not recur. A couple of them did have a second attack, but did not end up defining themselves as multiple sclerosis or something else.
And the MRIs show short segment enhancement.
So this idiopathic group is this huge umbrella of so many different things. There were some, I still actually remember there's 2 that are quote unquote idiopathic, and I thought for sure they'd be MOG positive. And, it's perineural enhancement, disc edema, and they're MOG negative. And, the question is, was that a missed test, or, some of these patients were getting the MOG assay 6 months or a year after the attack. This study was interesting. We actually, to try and get the blood from all these patients, a lot of them we have stored from the time of attack, but sometimes we had to call them up and get the blood later. And so, maybe they're MOG positive and it became seronegative. But yeah, it's a large umbrella. Some are going to be different antibodies.
Thank you, John.
Hello, Dr. Chen. I have a question.
Yes, of
This
course.
is Arnoldo Soto from Costa Rica. According to the Wingertion 2015 NMOSD diagnostic criteria,
Yes.
it is possible to make the diagnosis of NMOSD in patients who are actually anti-cooperative 4 negative, or in
Correct.
patients who the test is not available. Could you elaborate a little bit about that, please?
Yeah, so again, you can make, because the aquaporin 4 antibody is only 75% sensitive, that means 25% are going to be seronegative and still make the diagnostic criteria. And so if they have, if you're negative for aquaporin 4, you need to have 2 of the core clinical characteristics, not just 1, you have to have 2. And one of those texts has to be optic neuritis, transverse myelitis, or area postrema. And so you can still make the diagnosis if they're seronegative. And then they also had there, just like you said, if you don't have testing, if you clinically make that spectrum, you can still make the diagnosis. The one thing in 2015 that they didn't know about were antibodies against MOG. So again, a third of those are going to be positive for MOG. And so, yes, they meet the clinical diagnosis of NMO spectrum disorder, but they are a different entity. They treat it differently, different outcomes. So that's the one caveat. And so if we do make a diagnosis of seronegative NMO, they're negative for aquaporin 4, they're negative for MOG, we do tend to treat them like we treat aquaporin 4 positive NMO. We usually start with rituximab, and we treat recurrent attacks pretty aggressively.
Okay, thank you. And please, one more.
Of course.
Is that in the eculizumab and the inebilizumab clinical trials were included only patients who were anti-aquaporin 4 positive. And then satralizumab tests were included positive patients who were negative and also positive for the anti-aquaporin 4 test.
Right.
And the results were, in the patients who were positive for anti-aquaporin 4 test, 79% were responder to the medication. And only in the patients who were negative for anti-aquaporin 4, only 34% were responder. It means we are dealing with 2 different conditions. It means the anti-interleukin 6 is not involved in the pathophysiology of patients who are negative to anti-aquaporin 4. Could you elaborate a little more in that point?
Yeah, no, absolutely. It really shows that it supports that these are different entities. The IL-6 inhibitor, the satralizumab, you're correct, it really did not affect these patients that were seronegative. And it's important to know from a clinical perspective, and it's important to know from a mechanistic perspective. We still don't know how MOG antibodies causes disease. We actually don't even know for sure it's actually pathogenic. We know aquaporin 4 antibodies are pathogenic, activates complement. But for MOG antibodies, we actually don't know how it works. We know it's an excellent biomarker, but we don't know the pathogenesis of disease. But we can safely say that it does not work through IL-6 because a good portion of those seronegative NMO were MOG positive. For the eculizumab trial, it only included aquaporin 4 positive patients, so we don't know if eculizumab is going to be helpful for seronegative NMO. And we don't know if MOG acts through complement, but we think it does, but we don't know for sure yet. And nemolizumab was a little bit more mixed. May have some effect in seronegative NMO, but hard to know. But yeah, satralizumab really did not. So again, important to know clinically, it just doesn't work. And it's very helpful mechanistically too, as we try to get this sorted out.
Okay. You have other question here in the chat.
Sure.
When they say, great presentation, thanks. What extent do you see recent treatment with intravenous steroids or PLEG can influence in false negative aquaporin 4 and MOG immunoglobulin G results in serum? How can
Yes,
influence?
that's a good question. So can the treatment cause a false positive? You know, it probably can but very minimally. You know, one thing that I would do is I would probably go ahead and get serum before I treat. That'd be one thing. But for the most part, it probably doesn't influence it too much. You know, especially aquaporin 4, when you're positive, you tend to stay positive. For MOG antibodies, if you're positive, about 75% stay seropositive, 25% become seronegative. So, and that's oftentimes with patients being treated pretty aggressively. So, you know, can the treatment, especially plasma exchange, can that wash out the antibody? It probably can transiently, but not long term. So ideally, you would get the serum before treatment. If you did treat them with plasma exchange and then got the serum and they're negative, I would go ahead and check again, you know, 2-3 months later. But, you know, it doesn't permanently wash it out.
He has another question. He said, has a patient with MOG, optic neuritis, and the result of the test delayed a month. How do you treat the patient?
Yeah, so for MOG optic neuritis, the good part is the positivity of MOG doesn't actually influence treatment all that much. You know, we're not rushing to get them plasma exchange. We get single attack. We're not treating them with chronic long-term immunotherapy. And so waiting a month for MOG really doesn't change things too much. It's the aquaporin 4 that's a little bit tougher because those we are rushing to do add-on plasma exchange. We are rushing to add on rituximab to prevent attacks. So for those, you know, if it takes a long time for the aquaporin 4 to come back and they've got a severe optic neuritis, they're no light perception, you've treated them for a week and they haven't recovered, you know, those patients we sometimes just assume they might have it, and we might treat them with plasma exchange, and then wait for the result to come back. So having a delayed MOG assay is not going to influence things too much, but you know, I really wish we had a quicker turnaround with the aquaporin 4.
Okay. What long-term follow-up is done to patients with NMO or anti-MOG, that is MRI, OCT, etc.? How often do you check patients? Greeting for Mexico.
Yeah, so with Animo and MOG, they don't tend to have progressive disease. You know, their disease, they don't have this subclinical smoldering that you can get with multiple sclerosis. Their attacks are hard. In between attacks, they're essentially normal, and then they get hit. So, you know, I'll typically see, you know, a patient back in 1 year, and then I usually have them graduate from the neuro-ophthalmology clinic once I get that final baseline, and then just have them follow up with, you know, a general ophthalmologist just for annual eye care, or a neurologist just for annual care. But again, unlike multiple sclerosis, the attacks for NMO and MOG are so abrupt. They don't have that smoldering disease that you have to monitor with MRI after MRI. When they have an attack, you know it.
Okay, thank you. I have a question, Doctor. When do you consider that is the short enhancement and long enhancement? Because sometimes you can read in the literature that is long is like 40 millimeters, 70 millimeters. Sometimes it's confused.
Yeah, my definition that I use for our studies is essentially taking the optic nerve at the globe down to the chiasm. So that's the full length of the optic nerve. And then if it's more than 50% of that, that's how I define a long segment. So if a nerve, just taking the length. So I don't actually measure millimeters. It's just if it's more than 50% of the length of the nerve, the prechiasmal nerve, that's how we made that cutoff. And for aquaportin 4 optic neuritis and MOG optic neuritis, about 80% of them are long, whereas with MS, it's more like 20%. It's kind of like the opposite spectrum.
Okay. Do you consider
Ay,
the
sí,
patient?
escuché que está el portón.
Do you consider the patient that already classified as chronic relapsing inflammatory optic neuropathy must be reevaluated and request on any of these tests?
I think any patient with chronic relapsing inflammatory optic neuropathy should definitely be tested for MOG antibodies, because it explains 25% of them, maybe up to 50%. There's still unclassified antibodies that we don't know. Aquaportin 4 antibodies, NMO, it doesn't tend to cause that chronic relapsing inflammatory optic neuropathy phenotype. With NMO, they get these recurrent bouts of optic neuritis, but they're not steroid dependent. That's more of a MOG phenotype. So I would definitely check them for MOG.
For all patients.
Yeah.
Okay. Thank you so much. I think let me check. I think we don't have any other question. Let me see. How many plex sections do you do on average?
So we tend to do 7 treatments separated by every other day is typically what we tend to do for that.
Okay. Let me see. I think we don't have more questions. You have too many. Congratulations. Excellent. You have, excellent. You have people also from Santo Domingo. I forget to tell, sorry. But you have too many. Congratulations. Excellent. Great presentation. Thank you. Well, thank you, doctor. Thank you for accepting this.
Wonderful.
Well, very good. Thank you so much.
Well, thank you so much. I really enjoyed chatting with all of you. I hope to do it in person sometime soon, but this was great to do it over Zoom.
Okay.
Thank you very much, Dr. Chen. Thank you.
Of course. I hope you all have a wonderful weekend.
You too.
All right. Take care. Bye-bye.
Bye, doctor. Thank you. Gracias a todos. Los veo la
thank
otra
you again.
Los veo la otra semana. Gracias. Les estoy mandando el link.
Muchas gracias, Emily. Gracias. Adiós.
Gracias a todos. Muchísimas gracias. I will send to you the video and the congratulations.
Thank you so much, Emily. Again, thank you so much for the invitation.
Your
so much
paper,
fun chatting with you.
I read your paper. It's wonderful. The review about biomarkers and multiple optic neuritis is wonderful paper. Huh?
Oh, great. Thank you so much.
It's very good. Thank you. Goodbye.
Goodbye.